Thank you. I'm Andrea Restifo. I am the Associate Executive Director for Notre University Hospital in New York. I want to thank the American College of Medical Quality for continuing to feature these educational video sessions. Our goal is to enhance your understanding and interest in quality management topics. Today's talk illustrates the practical aspects of using big data, quality management methodology to drive change. Today, Dr. DeLugash and I will gain perspective from our colleagues from Long Island Jewish Medical Center on how they use data. And today, here with me is Dr. Yosef DeLugash, Dr. Matthew Foley, the Medical Director of Long Island Jewish, Matthew Pincus, the AVP, Clinical Quality Management and Performance Improvement Industrial Engineer, Roseanne O'Gara-Shabinsky, Associate Executive Director, Quality and Patient Safety, and Margaret Murphy, the Chief Nursing Officer, Associate Executive Director of Patient Care, all from Long Island Jewish. So thank you.
Good morning, I'm Matthew Foley. I'm the Medical Director of LIJ Medical Center. We are a tertiary care center, receiving facility for the region, receive many more patients than we transfer out. We have 583 licensed beds, 1,800 nurses, 2,000 physicians, 5,825 employees, and greater than 100 volunteers.
Good morning to everyone. Today we are addressing a very interesting topic, how statistics and data being utilized in healthcare. And we'll be giving you several examples of how the executives in this organization utilize the statistics and convey it as information to the rest of the population of the hospital and the greater healthcare system. What you see in the first slide is the outline of the presentations. Try to be in terms of a question and answer session. We'll talk about identifying measures and prioritization. How do we participate in the analysis throughout the hospital? How do we ensure that the data is correct and reliable and can be used, which is extremely important. And then how to turn the data into useful information so policies and changes in behavior can take place in the organization. The first question that I'm going to ask is how are measures identified and prioritized in this hospital?
So one of the things that we do at LIJ is to use data at the nursing unit level, and this is an example of how we collect data. We have scorecards that each nursing unit has, and we prioritize what is being collected. So a lot of our data that's collected at the unit level is nursing sensitive indicators, those things that nursing really has an impact in or actually control the outcomes for. So examples are our falls, our pressure injuries, our CAUTI, our CLABSI, our MRSA, our C. diff. So we look at all the nurse sensitive indicators, and we are a magnet facility, and magnet is the gold standard for nursing. And as a magnet facility, we are always benchmarking our data against like hospitals across the country. So there's a big three, they call it in magnet. It's the criteria that you need to meet in order to really apply for magnet and to hold that designation. There's only 8% of hospitals across the country holding that magnet designation. So the big three are, you have to meet it on patient experience, you have to meet it on RN satisfaction, and you have to meet it on your quality outcomes. So I'm happy to say that we are in the process of going for our third designation for magnet, And the way they measure it is you need the majority of your units, the majority of the time, which we measure in 8 quarters, to outperform the magnet benchmarks. So greater than the 50th percentile. And we just sent in our document for the 3rd time. We are waiting to hear. And we are very excited because we are very confident it will be accepted because we met all those criteria. So we are expecting to have a magnet site visit this morning. But data collection plays a big role here for nursing. Everything that we measure, we are constantly trying to improve. So we work with the entire interprofessional team. One of the things that we saw last year, and we've struggled with it, is MRSA hospital acquired. So we looked at it, we did a lot of research on it, we had a whole team working on this, and we looked at hospitals that had a best practice, and then we sat down and we looked at the screenings that we were doing, and we actually, based on our population, we changed how we screen for MRSA on admission. Being on admission and treating appropriate patients who came up positive, that in and of itself will help decrease the spread. Also, we worked with infection control, who worked with our EDS team to look at how we're cleaning rooms and to really use the latest technology to do that. So you can see in the last quarter of 2023, we actually outperformed the CMS survey for the first time in a long time. And I'm still very happy to say that for the first quarter of 2024, and I can include April and May, we are still outperforming the CMS survey. So data plays a huge role for us in nursing in everything we do. We are, like I said, consistently looking at that data, looking at scorecards. The managers at the unit level and the providers at the unit level have a shared responsibility to really look at all the data and work together. And when there is something that is hospital-wide, we will get a team together like the MRSA and really work to reduce that.
And I would just add that the questions that we have drive our data, and then the data drives the questions. So in the question that we're trying to answer, how do we prioritize and how do we find the measures? For example, falls is something that we want to improve on, and we had that on the first slide. MRSA is too. But then we start collecting the data, and that drives further data, like which unit are the falls the worst? And then why? Maybe we have a suspicion that post-operations we have more falls because it's an ortho floor, but we're wrong. So then we have to look at the other data where our higher falls are. So it's a constant cycle on looking at the data, driving more questions, and then asking Matt Pincus what other data we can collect to narrow in on the answers that we want to perform new initiatives.
And Dr. Foley's that point with the falls, I'll just bring up, a couple of years ago we noticed we were having falls on postpartum. And we weren't really sure why. So with a lot of data and a lot of backtracking and looking to see what the historical data showed us, we found out that we needed to do orthostatic blood pressures the first time the patient was getting up. So now we do it the first time the patient's getting out of bed in L&D, if they're getting up, and we do it the first time the patient's getting out of bed in postpartum. And we have actually managed to almost eliminate falls in postpartum. We are so close to eliminating them. It's been a tremendous reduction. So good point about the falls.
I have a question. It sounds like you all utilize a large amount of data. So one is that in your busy schedule, and typically the nurses on the floor, the physician, do they have time to look at data? This is one thing. And then, how do you make them look at data? In other words, do you orient them when they come to the hospital as new employees, or you provide ongoing education?
So every nurse leader has an orientation when they assume that role. And most recently, in the last couple of years, we've added a nursing leadership course at Northwell, and Matt actually teaches how to look at data and what data is used for at that course. He could probably speak better to it. So yes, they all know how to use data. They all know the purpose. They all know what we need to do with it. They all know that we want to do continuous performance improvement. So they are very well versed in the use of data. And as far as time goes, that really is a priority, because if you want to deliver safe patient care, you can't possibly manage safe patient care without knowing where your sort of hotspots are. So the data is super important.
Yeah, and I think, the question is, how do you bring the data to the bedside, I think? And, the bedside has all the examples. They have the experiences, they have the emotion, they have the patient that fell and broke their hip. And when you can use that emotion and bring the data, well, your unit actually has 7 falls this year. This other unit had 1. Maybe we can learn from the other unit on what they're doing and bring the data to the bedside to show how you can improve.
This is great. So we have also a couple of slides on Florence Nightingale.
So Florence was way before her time. She was just a phenomenal nurse, a phenomenal leader, and a phenomenal statistician. She really changed how we look at infection prevention. Her first graphs were spectacular. She had people who knew nothing about statistics looking at her graphs and understanding that the mortality rates in the Crimean War for the soldiers who were wounded were actually less than just all the other mortality rates. So she changed how we looked at it. She was definitely a pioneer, and she is the founder of modern nursing. To this day, much of what she did, we are still doing. She collected data, she analyzed data, she did it on paper. We're more sophisticated now. We have industrial engineers doing it. But she led the way for all of us. She really and truly, and even with the MRSA, it's hand hygiene, the most important thing. And hygiene was her big thing, and making sure that every place was clean. And that's why infection control worked with EVS to make sure they understood. So we still follow Florence to this day.
I want to let you know that when I created quality, I used Florence too. And what really impressed me about her, that she was able to convince the military authorities and public politicians to change practice.
Yes, she did.
In terms of cleanliness,
Mm-hmm.
air exchange, and so on.
Yes, and the water supply, and she did a phenomenal job. So a lot to be learned. I think we did learn a lot from her.
Yes. So before I go to the next question of how do we participate in utilizing methodology and toolboxes that is going to be presented, another thinker that helped to shape quality in this organization is Deming. Everybody is using Deming's without completely understanding what it stood for. But besides knowing statistics, he also tried to figure out, like Florence, how to shape policy, how to make change in the environment that he worked. In fact, industrial engineering is where it started. And he used the tools that will be illustrating soon to change the way mode of production took place in Japan, of all places. And this is really fascinating to understand, and also it can help shape people who think about data. So basically what he's saying here, the data is not artificial, it's not an external indicator, it's internal, like Florence did. And he said without data, it's only an opinion. With data, you may affect if the data is good. So it's really great to have such thinkers that shape the way we deliver care today and quality management. So as a result, we would like to hear today now what kind of methodologies we have here and the toolbox that you utilize to teach and implement in this organization.
Yeah, so as Margaret was saying, in Nurse Leader Beginnings, we're teaching a lot of these different tools to our, frontline nurse managers. We really focus on the PDSA methodology and empower our frontline nurse managers that they can do a PDSA, on a very ongoing basis, right? It's continuous quality improvement that they're looking to do. So they have the data available to them through various dashboards that are given to them each month. So they don't have to track a lot of the data. It's the outcome data is given to them, and they're able to focus on doing process improvement with a PDSA methodology. We've also looked at educating them on the different lean tools. So when they have a problem, focusing on that current state process and mapping out that current state process, getting the frontline workers involved in the process, in this, all the different stakeholders and roles in that process in the same room to discuss how they're currently doing it, and they're really learning from each other when they do that initial evaluation of what is our current state process, where do we need to improve, and that discussion facilitates lots of different ideas on how to improve. And those ideas are all become PDSAs. They all become that ongoing, we have this idea or thought, how, does it work or does it not actually work, right? And the only way to figure that out is to test. So you test this change and you see what works, what doesn't work. If it does work, then the next thing we tell them is, great, you figured out what works. Now we have to make sure we sustain that improvement, right? So we teach them about standardization and standard work processes. So a lot of different tools that we're teaching, so that we can improve and sustain improvement.
This is really great because when I walk on the floors, there will be dashboards.
Okay.
And one thing came to my mind as you spoke, as the nurse comes in the beginning of the shift, she has a list of issues with previous shift, and she knows the census, maybe population that she serves, and then she looks at the dashboard. So, any comments about that? From a medical point of view, do you have the same thought processes that goes on?
Yeah, I mean, I love dashboards. We look at that, that's the first thing I look at in the morning. Can't wait to see the morning dashboard, how many discharges there are, how many admitteds, and what it looks like. But, kind of to that point, when we're building a dashboard, we want to make sure that it's reliable. We can make numbers look however we want, but we want them to have meaning. So if I'm just looking at the discharge yesterday, all our discharges aren't as important to me as our med-surg discharges or our tele discharges or how many long length of stay patients left yesterday. So on that dashboard and on that data that we look at, we want to make sure that it's going to be meaningful, that we can act on it at any given time.
This is great. It's absolutely great. So this gives you enough data, a lot of meat.
Mm-hmm.
And the data is really practical that everyone can use, right?
Yeah, and we teach them to not only rely on the outcome data, but look at the process data as well, right? So if you're looking to improve falls, you wouldn't measure every day, did we have a fall or not? Most days you're not going to have a fall. You'd want to look at the process. Did we do everything we know that is going to be effective in preventing falls, right? If the bed rails up, do they have the red socks on? Do we identify them as a fall risk? Are we proactively toileting them, right? So you'd actually measure those different processes, and you can track, how often did we do those processes in real time? Did we have any fallouts? If so, why, right? And learn from that. We have something called a Gemba board on the units, where every day they're looking at some process metrics, seeing what the fallouts are. Gemba means the real place, or where the work is being performed, Japanese term.
Okay.
And so they're, actually on the units, they're collecting daily, data on a process metric, and they're putting it in a run chart so they can see, are the changes that they're making effective or not effective.
Matt makes a really good point, because we have the data at a high level falls, but then we get granular and we get the data on the data, and that's the processes that we implement, and getting those processes is what drives our quality.
Yes, so I understand how the nurses do it. They participate, they collect, they think about it. They really don't have to go to school to study statistics, because you provide the statistical thinking or philosophy about particular numbers. So from a medical point of view, do physicians also participate at the same level as the nurses?
Maybe too much. I think the physician side are more skeptical of all of the statistics. There's a lot of researchers, and so they know that we can shape the data to look however we want. And so they are looking on how the data is completed, what's the total N that was, how impactful is this number, we will get that a lot. So not only look at the data, but critique the data in a good way, and then we can change the data so that it's interpreted by the physicians in a way that's more welcoming. And that's one of the more difficult parts to get across to the physicians, to say, how real is this data and how does it represent what you're doing?
Wonderful. So one of your tools that you have is the control charts. And can you give us kind of a brief overview of how you implement or interpret the control chart?
Yeah, of course. So at its core, a control chart is a run chart. Where it's showing data, rate or performance over time, right? So it could be either an outcome measure, such as a quality rate, right? So that's our, our rate of infections per 1,000 urinary catheter days, as you see on the screen, or it could be a process metric, right? Where we're looking at, did we follow, the insertion bundle for a urinary catheter? So, and a control chart can identify if a process is in control or out of control. And what I mean by that is it going to produce the same results that it's done in the past? Or are we seeing a shift or a change, a significant change in performance of this outcome? So, on the chart here, you have that we have an intervention, and you see some points that look like they may have benefited from that intervention, right? So you can use data and statistics to see, did we see a significant change, or is that change just a result of normal random variation?
Great. This is great. And you also talk to them about the benchmarking in this particular control chart.
Yeah. And you can use the control chart to, again, to see if you have that. There's different rules to look at. There's special cause or common cause variation, right? So if you have that common cause variation where it's just normal variation, you have a stable process, and you'd want a common cause strategy looking to improve your process. If you have, an unstable process where you do have special causes, right? Points that, typically you'll look at, see if there's any points more than 3 standard deviations from the mean. You may need to do a root cause analysis. What happened during that time frame. The most recent special cause you can probably is the pandemic and COVID, right? We've seen a lot of points that ended up 3 standard deviations from the mean because we had a pandemic and things were, it was a special cause on a lot of our charts.
So the next area of data is that how do we ensure the data is collected in a reliable manner, in a reliable way? So one thing that came to my mind is that as you do rounds on the floors, you talk to nurses about data, right?
Mm-hmm. Yeah, correct.
The same thing to physicians?
Mm-hmm.
Okay, this is great. So how do we make sure that we collect data in a reliable way?
I think it's a process of, we're never satisfied with the data that we have. We are constantly refining it to find the answers that we're looking for that can be impactful. So we are checking with the people that are doing the work and using the data, and they will give us feedback to say, oh, well, yeah, but I don't work on Wednesdays, so your data is off, and then we don't realize that. And the people that are running the data, they'll say, oh, well, we accounted for that. We know that you don't work on Wednesdays, and that's why it's within the standard deviation, and you're a little off here, but it's within the realm. So it's constantly asking those questions for everybody involved, the people doing the work, the people analyzing the data, and the people performing the data, doing the statistics.
This is great. I can't resist one question, which I didn't put.
Don't
Is
resist.
that in terms of reliability, I recall when data was presented by different hospitals, let's say to medical leadership, the corporate office, all the numbers are different because the performance is different. Some look good, some don't look so good, some look very bad. How do you cope with this type of situation?
We call each other. Yes, we definitely share. We share with each other. That's the best thing about being in the system is that we share with each other. But when we do look at our indicators that we're going to be using, when we develop them, we agree on what are the definitions, inclusions and exclusions, so that we're standardized, so we're looking at the same data. Because we don't want to have everybody putting in their own and not looking at the same standardized data. So the numerator is the outcome or the event, the denominator is the population or the opportunity. And so that's why when we look at data, it's the same, so that we make sure that we're all in the same, standardization.
Yeah, and in the beginning, there was a lot of different hospitals producing their own dashboards, and they may have, defined the numerator denominator differently. So thankfully, we have, within Northwell, organizations like the Krasnov Quality Management Institute, which we refer to as KQMI, does now actually produce these dashboards, and they post them through a Tableau link where all the hospitals have access to them, and they can actually see, since it's an, that entity within Northwell is producing these dashboards, they're all using that, they're able to standardize so that we're all looking at the data in the same way, using the same numerator and denominator.
And you're right, it always begs that question. When you see one facility that is different, whether it's within the system or outside the system, you're always asking, are they really that good or bad? Or are they just collecting the data differently? And then you ask both questions and you kind of find the answer. And if they are really that good, how can we replicate that? Because they are collecting the data the same way we are.
This is great. It's absolutely great. I'm sitting on the board, so I have an opportunity to look at data from all of the institutions. And I was really surprised that there is no screening or yelling when we invite different hospitals to the meeting. So this is it's really good, and you see over time that the performance is improving, it's changing. The deviation doesn't exist so much from the mean. So this is not bad. It's really not bad. So this is why another way of making sure that your data is reliable and valid. Besides the test that he does.
Yeah.
With a very extensive formula. So I'm really absolutely fascinated with this Gamba board example. And with a beautiful picture of it. And I would like to, if we can share all this. Can anybody make a comment on this?
Sure. We started about 7 years ago trying to take a look at how the staff could be participating in their key performance indicators. So we decided that we would use the tool Gemba, which we had already described before. It basically means to go where the work is happening, because that's where you're going to learn the most, not from where I sit, but from where the work is actually happening. So we have leadership involvement, where we go every week to a Gemba walk, where the staff have the opportunity to tell us what they've been working on, any barriers that they might have, any PDSA that they've been working on. And Matt actually gives a class on Gemba, and you can explain a little bit more about that.
Yeah, if you go up to the next slide, you can see some of the elements of the Gemba board, where, as I was describing before, there's some sort of performance indicator, some process measure at the top. Each day they're looking at a run chart, is the next document on that chart, to see how many times, if they audit 5 or 10 patients, how many of those patients met or missed the goal. So say they have 2 patients that missed the goal, they're going to ask why, right? What is the reason why that target was missed? And they're putting that on a Pareto chart to see which reason is happening the most often. And then from that Pareto chart, that they're filling in daily, they're saying, okay, the reason that we missed the goal is, again, maybe it's that they ran out of red socks and that they were supposed to do that for identifying the fall risk patients. So on their action plan, they'll assign someone to, reorder them, right, on a monthly basis. And they'll hopefully never have that problem again because it's assigned on that action plan. On the right-hand side is a totally separate board where anytime they have a problem or an idea, they're able to fill out an idea ticket and visually, again, another lean tool is visual management, visually track that idea from start of the idea to completion of the idea. And in that way, it's, it doesn't, anyone on the unit can own an idea, and the manager doesn't have to keep track of them all. They're right there on the board. And that, again, gives a way to keep organized and work on ideas that the staff are, contributing.
Yes, and some units own it more than others, obviously. One example that I wanted to use, and it kind of comes back to the data at the bedside, is the call alarms. One unit wanted to make sure that the call alarms weren't ringing for a long time, so they wanted to have a higher reaction time to get to the bedside once the call alarms. And they shrunk it pretty quickly, but they realized their data was flawed because what they were doing is they were just asking the unit clerk to turn off the alarm. And so they really weren't getting to the effect they wanted of getting the nurse to the bedside in a fast time. So then they had to rearrange their Gemba board. It's like, you can't have the unit clerk turn it off. You have to turn off the alarm at the bedside. And so they could actually affect the goal that they wanted to by changing their data on their own Gemba board.
This is great. So this Gemba board is led by the nurses and the physician.
Yes.
Yeah. It's a
Did
partnership.
you get any reaction?
They love it.
They love it.
They love that they're able to have an idea, put it on the board, they huddle around the board, talk about it, decide if they're going to move forward with it or not. Most times they move forward with it, and then they see the end result that there's been change made. And then they get to tell us what they were working on.
I have another question, please. Now that you implemented it here in this building, you have 2 more buildings, 2 more hospitals. You are geographically quite far from you. You have the same methodology there too?
Yes, starting.
It's spreading.
Yeah. We need to regionalize all our data, and Matt Pincus has been doing that quite effectively to see how we can collect the statistics and the data equally throughout. And then also, we now have a regional performance improvement committee that we try to attack the problems that we have or solutions that we want in a similar manner.
Yeah, but what lessons do you have from there to teach other organizations who are not part of this system? I mean, people are going to listen to us from across the country. So do you have any recommendation to make based on your experience with other hospitals?
I think the biggest, recommendation would be to get the leadership on board first, right? Nothing's really effective unless you have a leadership buy-in. Really, working with the people, on site, the local leaders, is really the way to drive change. And once they buy into it, they're really owning their own data. That's where you see, they're more willing to accept, help and bounce ideas off of. We're able to bounce ideas off of each other once you have that buy-in.
Yeah, it was really true. When we started, Matt, going to some of the other facilities, I would meet with my counterparts, and there was a reluctance actually to take the help at first. And I think one of the areas where we might have had some success is we asked, well, where's your biggest pain point? How can we help with that? And they said, well, maybe we could have, some help in, our readmissions because we really want to improve on that, but we just can't get the data. Well, I am the perfect person, and then they would start to welcome that in.
Because don't forget one big thing with Thailand, it's not so much about the data. It's more about losing control of your destiny, losing control of your function. losing control of your thinking. All of a sudden, Big Brother tells them what to do. This is the biggest thing. So from a quality point of view, how do you overcome it?
Once they start to see the small wins, then they start to really want your help because they've seen it from the beginning. They didn't really think that anything would happen, and then we start to have small wins when we're working with them, and then they can't get enough. Then they really want to embrace it, work with us, and I think that's how you win them.
And from a nursing point of view?
I think just explaining the why behind what we're doing. Once they understand the why first, then we'll talk about the how and the what kind of thing. But understanding that why. So it's really important, I think, at the unit levels for the nurse managers when they have huddles to talk about the data, and they do. And they talk about the data at the GIMBA board, but they talk about their scorecards and explain all the reasons why we do what we do. And that gets them there.
It's great. It's very nice. I think that.
Is there another question?
Oh, the last question that we have is that how do you turn data into useful information? And basically, from a medical point of view, we again looking at the medical, because physicians typically are reluctant to change. They are the most conservative group for people. So how do you take your medical staff, which is in the hundreds, and you help change or drive change in this organization, and even changing their attitudes?
Yeah, it seems that it's only useful when we hit our goal and then everybody believes it and say, oh yeah, we're perfect. It's really difficult to get people to identify their flaws and agree with it and say that, oh, this data is saying that I'm not doing so good and I have to own that. Then they just kind of pick apart the data. They say, oh, this data isn't correct. It's because of this and this. But often to get to be useful is when, I think when you can, it's not convincing when they understand that they need improvement in a certain area. And it's all, most helpful is when staff comes to us. That I have a problem with this. I need a turnaround time faster in the OR. We need to get people back on the beds faster. Then they believe all types of data, and it becomes more useful.
This is great. So we had a very nice session today.
Absolutely, really.
So really, it's unbelievable. We have a few more minutes, so we'll go to end of life, which is a very important topic in healthcare, right? Because we changed also the way we look at mortality and the way we look at quality of life. And in fact, getting certification in hospice care is a recent phenomenon, if I'm not mistaken, to physicians. So would you like to make a comment on that?
Yeah, this is a screen of goals of care, and maybe initially we want to do what's best for the patients at the end of life, what the patients want, but it goes into so many more aspects of how our hospitals are run. Because if we can get the patient's goals of care on paper, we can give them a treatment plan that's acceptable to them. It also helps us when they leave the hospital on what their goals are, and we can set them up for the best outcome after they leave, which in turn helps us and decrease readmissions. And that's an improvement for us when we have a very busy hospital and we want the appropriate people in this hospital that need the care in this hospital. And sometimes that also aligns with the patient's goals of care. So it's not only end-of-life care, it's really doing what's best for the patient and what the patient thinks is best for the patient.
You want to make a comment?
Yeah, I agree with what Dr. Foley said. One of our biggest challenges is unfortunately when we have patients and we don't know their goals of care and their acuity is so high. And then we have patients also who want something, and we just had one yesterday and the family doesn't want the same thing. And that really makes it very challenging. So end-of-life care is very complex. It's not just about end-of-life. It's about all the other aspects and taking care of the patient's wishes, making sure the family is involved and that they're okay because we can't separate the two. So complex issues, and I think, we have a great team working on it every single day. I think we've made tremendous strides in it.
This is really great because the population of patients in Long Island is increasing in age, including myself. So this is really, it's wonderful. You're focusing on it, and from a quality point of view, the measures are the measures, the same measures, because you now check on falls for the very elderly, skin care for the very elderly, and so on.
We still want to give them the best care.
You want to do the best. This is great. So the gamba on the geriatric floors is very active.
Just like every floor. Everyone's looking at data, they're looking at dashboards, and they're using it to drive change.
So we have, I think, 2 more minutes, and couldn't resist. We have a beautiful approach to prenatal care through measurements. And anyone who wants to make a comment on that?
And a control trial.
And the controls, so yes, you will have to make a comment.
Yeah, sure. So we did, we were looking at our NTSV rate. So that's, looking at this rate, we saw, we didn't have a lot of change over time. So we worked on some interventions, having, rock and roll. There's some evidence based around that. So we really looked at seeing if we can roll that out with the nurses and the providers, working with our moms. So we, did some, created some champions to really own that process. We distributed badge buddies, and then, really started giving out that education, giving out manuals, badge buddies, and units, and really making it the culture here. And from that point, after we had all that culture change, the education rolled out, and the champions really on board, we were able to look at our data over time from that point. And as you can see on the chart, we saw 8 out of 9 points below that mean. So we were able to say, hey, that really is a slight change in the process. So we need to recalculate our control limits, as you see that we did on the board here, and show that our process has a new range bound, right? So we are statistically significantly better than we've been in the past, and we can show that on the chart.
Yeah, this is the beauty about control charts. It doesn't want to control the process, but it also when you change the process, you can follow a new mode of production, a mode of change, whatever you want to call it. Thank you very much. So, using data to make decisions, what gets measured and so on, quality is, I'm sure, very involved in that.
Yeah, so as you said with Deming, it's just an idea unless you have the data. So whatever we are measuring, it does improve. So it's amazing. We look at things weekly. We have physicians, nurses, and others report out on metrics that are important.
Right.
So it's great to see how we're improving each week.
Yeah.
Comment?
I think it's a great quote up there. You have to measure it, but you have to manage it. And if it's a consistent measuring and consistent managing, then it does improve. I mean, the previous slide of the C-sections, there was multiple interventions.
Yes.
We were measuring it through the whole time. We had to continue to manage it, and then it improved. We followed the data.
This is great. This is great. So this is, I think, the last slide that we have. It's really a very beautiful and very busy slide in terms of, I like the concept of showing the data relates to ideal patient care. Can Nelson make a comment on that?
I think when you put all of this together, it definitely is a recipe for becoming a high reliability organization. I think it really drives patient safety. I think the partnership between all the disciplines And we really have that in this organization. I think every discipline relies on Matt and his team to really know what data they can impact. So it's an incredible collaborative effort, kind of like that slide. They're all sitting there next to each other, every piece of it, and that's how it works here. We're all sitting in the same room together, and that's at every level.
So your goal is to achieve a highly reliable organization.
Yes.
In other words, you can predict
Mhm.
to some extent, maybe 10%, you can predict certain measures, certain success. We didn't reach this level yet of statistical analysis, but eventually we'll be able to correlate it with patient satisfaction. So this is really great. I really enjoyed this session very much.
Today's session really showed the value of having an industrial engineer, having data available, getting frontline input to really drive change at Long Island Jewish Medical Center. So I want to thank the team that's here with me today for this wonderful educational session, and we'll open it up for questions. Thank you very much. Thanks, Skylar. I know Matt Pincus is live. Hi, Matthew. And Yosef Delugash is live, and we're here for any questions. And I saw one earlier in the chat about how we ensure our data is not only reliable, but valid. And Matt, do you want to take that first, or Yosef?
I can let Matt start and I will finish.
Yeah. So how do we ensure our data is as valid and reliable? It definitely depends on the type of data, but if you take something like, get with the guidelines with stroke abstractions, we are consistently doing iterative reliability. So basically where you have two separate, clinical quality abstractors reviewing the chart for data and information within the chart. We're having them review a sample of the same charts and looking at the agreement between those two abstractors to see where, how often they agree, with the data. It's in that way we're able to create iterative reliability rate and look at really what is, is the data valid or not. If it falls below a certain percentage, usually we use 90%, maybe time for re-education, and to look at performing those abstractions again to ensure we get that rate above 90%.
Okay, very good. Of course, I agree with Matthew. The way I look at validation of data, there are two parts to it. One is a face value, which means that the clinician who are targeted with the result think that the results make sense. So this gives you one opinion about the way we collected the information. So if there is no consensus, let's say one hospital thinks that the rates are too high, while another thinks that we are too low, or there is something missing, it's good to know. So you get this type of feedback. The second is what Matthew mentioned. It's much more derived based on statistical analysis. The reason that we are doing it, as you all know, is that the data we collect is for medical record. And in the medical record, the clinician can have his own subjective information. So to collect this type of data, you need to be consistent. And typically we have quite a few nurses who review the information, the medical record, and they try to collect it. So besides, as we define the inter-aid reliability and trying to figure out where the errors take place, we also develop checklists. So if we talk about, let's say, a particular infection, we want to make sure that the definition is the same as understood by all the nurses that collect the information. So in this way, we can make sure that the data is valid. And as Matthew mentioned, we need to check it on a frequent basis, especially if we deal with a large amount of information, as infection or mortality. So I hope we answered your question.
In fact, Sharon actually put more in the chat, valid from the perspective of structured and
Yes.
unstructured data. Is the data extracted from both sources? And then, so yes, we abstract from both sources. And I
Right.
think the hardest part is from the electronic medical record. There's so much data, and we tend to do random audits of that.
Yeah, I want to make a comment. The unstructured data is the most common data that we have. Because in the electronic medical record, we are trying to create fields that explain a particular variable, like a checklist, but it cannot happen all the time. So most of the time, as Andrea mentioned, it's unstructured. So in this way, we really need to review consistently the data that the nurses pick up through the progress note to make sure that their understanding is consistent. If not, then we have a problem. And then we provide, as you mentioned, Andrea, re-education, and Matthew mentioned it too, of the nurses. So it's constant checking the information, checking the statistics to make sure it's valid and it will be accepted by the users, the physician or the nurses.
And I also would say on the unstructured data from the medical record, we have different layers of reviews. If nurses can review the nurses, but we also have a provider through our coding system that, really validates with the quality nurses about different complications that we have. IT has a system to make sure that they're checking that we're taking the data from the right part of the medical record. It's not 100%, but we definitely have different ways of making sure that data is good.
Oh, I would love to answer the third
You have
one.
to read the question,
I
but
read it.
Matt, do you have anything to add?
No, it's okay. Go ahead.
Okay, I love the third question. I'm a federal clinical quality measure
person.
developer since 2010, and would enjoy hearing how the measure content is mapped in the electronic medical record. And I'll get to the next part of the question. This is a great question. This type of an answer, I'll try to figure out how to give you multiple answers because it's very hard to map a particular measure. So we do have, before we map a measure, we have a committee of clinician, physician, and nurses, and at times other type of clinician like respiratory therapy or physical therapy or dietitian or nutritionist, depends on the measure. And what we do is that we'll discuss in a group the content of the variable, which means we look at the numerator and denominator, and then map it in a certain logic in terms of data collection for the electronic medical record. So there are quite a lot of steps that takes place in defining a particular variable. So even if I look at, let's say, mortality rate for cardiac surgery, we will have to map the death itself, which let's say yes, no, but then we'll be looking at all the variables that can explain those who are dying and those who are alive, let's say post-surgery. and to see what other independent variables exist that can explain the differences between yes and no in mortality. Once we define it, we'll map it, and we'll try to develop a checklist so when we collect the data, we can understand it better. So we'll be looking at secondary diagnosis, let's say. We'll be looking at complication. We'll be looking at other condition, underlying condition for the patient, and so on. And all of this we map in order to retrieve the data that can explain the dependent variable, the mortality. And then the next part, which you said, is how do you make sure what how we as developers are intending to assess is how it is implemented from boot. Well, this is also a very extensive process, and the way we do it, we constant check for validation of the data collection, and we provide extensive education to the people who collect the information. So to make sure that we are consistently have the same variables in the development of the measure. Andrea, you want to add anything?
I think from the ground perspective, we still struggle a little bit with, let's say, just getting the accurate line days or Foley days, because sometimes the order and the documentation doesn't match. But that's when we, do that random sample to validate and also say, this is a good source of data or it's not a good source of data. What I think is helpful data we get on pressure injuries is that when we, from a nursing perspective, we have an expert look at that data to really make sure that it's staged accordingly and treated accordingly. So for different measures that are consistently defined, and this is the power of the system, we do have ways to ensure that, yes, that's good data to use or not good data to use.
Yeah, but with the pressure injury, for example, you have a committee of multidisciplinary members who participate in these activities, and you all talk together to figure out that the measure is consistent.
Yeah, I would say we do that more for falls now and pressure injuries. We have more of
used
the
to do.
expert team.
So we
Right.
have
Mhm.
more experience,
Yeah, definitely.
but it's the same process for every measure.
Matt,
Matthew?
No, and I would say probably one of the biggest challenges is, sometimes, there is data in, a free text field and it'll conflict with data that you see maybe in a discrete field. And that's where, again, having nurse abstract or someone actually reviewing the chart, to validate data is really helpful. To look at that, and a lot of times we'll work with our IT colleagues, say, hey, we found conflicting information, and then they can update the report, and maybe sometimes it just ends up being that they give us both pieces of data, right? So recently I was looking at a stroke report, and we do BFAST screening when our patient with stroke symptoms arrives. So we actually looked at pulling the triage BFAST screening, as well as maybe if it was done again by EDRN shortly after triage. So we'll actually pull both of those into the report to see if there's agreement and looking at that data by checking both sources.
I'd like to add, great, thank you. I would like to add to the one thing is that any measure that we have to make sure also that the audience accept it. So if you decide to measure mortality rate for cardiac surgeons, you do want to get their input into it, and you want to make sure that they understand and they accept the information, because this information can change the way they practice medicine. So this is also a very important component of validation of measurements.
and I know we're at time. I really want to thank Sharon for your questions and your comments and your compliments, and Matthew and I and LIJ colleagues I'll look forward to contacting you in the future and carrying on the discussion, because we talk about this for a long time.
Yeah, is it, another question, I think. No, Andrea?
No, we had a compliment.
Oh.
We're at time. Say goodbye.
Okay, I guess we are out of time.
Yeah, 2:00.
So,
Thank you, Matt, and the
thank
Long
you.
Island Jewish Medical Center Medical Director, AED of Quality and Nurse Exec for making that video for us all today, Matt, for joining us live. And
Yes.
Thank you to the American College.
Thank you very
Thanks,
much.
everyone. Take care.
Thank you.
Thanks, Skylar.